there's been such a push that you must use a patchouli gel, you must use body identical progesterone, that no one knows how to prescribe anything else within the range of safety. And everybody's just saying, oh, everything else is dangerous and terrible. It's actually not. And there are lots of ways you can use alternatives to patches and gels and progesterone very safely, very effectively.
Welcome to the Redefining Midlife podcast. I'm Jo Clark and I'm so glad you're here. And this is a podcast for women who are ready to break free from outdated stereotypes, rediscover themselves, and embrace the endless opportunities that midlife brings. Each week, I'll share expert advice, actionable strategies, and inspiring conversations with incredible women who are redefining what it means to thrive in midlife and beyond. From health and wellness to reigniting your purpose and passions, this is your go-to podcast for feeling empowered, supported, and seen. And midlife isn't the end. It's your time to shine, rewrite your story, and create a life that you truly love. So let's get started. Welcome to episode 125 of the Redefining Midlife podcast. Now, this is an episode you won't want to miss. It is one to save, revisit, and share with every woman you know. Today, I'm joined by Professor Susan Davis, one of the world's leading experts in women's health, hormones, and menopause. In this conversation, she breaks down the facts and the latest research that will empower us to live well, not just today, but for decades to come. And we live in a time where misinformation is everywhere. Social media is flooded with unqualified celebrities, health influencers, and even some well-known women's health professionals sharing misleading or simply outright harmful advice. Many promote expensive, unnecessary products that don't work. That's why this episode is so important, because knowledge is power and getting the right information from the right experts is essential. Now, Professor Davis, AO, is a clinical researcher with expertise in the role of sex hormones in women across the lifespan. She is a head of the Monash University's Women Health Research Program, consultant endocrinologist, and head of the Women's Endocrine Clinic at the Alfred Hospital in Melbourne. And she's a consultant at Cabrini Medical Centre. She is a fellow and council member of the Australian Academy of Health and Medical Sciences. Now, Susan's research spans basic science to clinical trials and has been pivotal in our understanding of sex hormones in women in multiple non-reproductive target tissues, including the brain on cognition, mood, and sexual function, the cardiovascular system, looking at lipids, vascular function, and coagulation, and other tissues, fat, muscle, joint cartilage, and bone. Susan was one of 5 founders of Jean Hales for Women's Health. She's been a past president of the Australasian Menopause Society and the International Menopause Society. She has over 435 peer-reviewed publications and has received numerous national and international prestigious research awards. Susan was appointed an Officer of the Order of Australia for her distinguished service to medicine, to women's health as a clinical endocrinologist and researcher, and to medical education. In 2022, she was awarded the Medal of the Royal Australasian College of Physicians for her outstanding contribution and leadership in endocrinology and women's health. She's an advisor to the NHS Menopause Improvement Program Steering Committee and was an advisor for the Australian National Women's Health Strategy 2020-2030. She advocates for the best clinical care via co-authorship and international best practice guidelines, and working with industry to ensure the health needs of women are understood. She's spoken before national, which is TGA, and international regulatory bodies, the FDA in the US and the EMA in Europe, as an advocate and an advisor. As you can see, Professor Davis's absolutely incredible knowledge, her skills, and her ability to condense all of that knowledge in a way that we can understand is what makes this particular episode so important for us to listen to. And you can find all of the links that we've mentioned during our conversation in the show notes. And I also encourage you to follow Professor Davis on her new account on Instagram. She's creating a lot of informative videos, short videos that you know are based on the very latest and well-researched facts. Now, remember to share this valuable information with your friends, your families, and your colleague. Now, without further ado, let's welcome Professor Davis. Thank you so much for joining us on the podcast today, Professor Davis. It is truly an honour to have you on the podcast.
Oh, thank you for having me here. I'm excited.
So I'm very much looking forward to you sharing your knowledge with us today, because with all of the noise that we've got on social media about hormones and menopause, combined with the marketing and that hard sell that we sometimes see from famous midlife women, influencers and businesses to buy products that are so-called a magic solution to various menopause symptoms, it really is becoming increasingly difficult to know what to believe and also who to believe. And I've got no doubt that our conversation today is going to help us enormously. But before we get into the learning side of things, and I'd love to hear, and also hearing about your incredible current work and research on hormones, I'd love you to share a little more about how your career path has actually led you to your work today. So when did your interest become a passion and your life's work?
A difficult question to answer. So I never expected to end up here. So when I was a young endocrinologist, which means training to be a hormone specialist, I was really interested in IVF because those were the exciting days of IVF. And I went to train under the late Henry Berger, who was an expert in this field. And in my training, I had to do the menopause clinic, which I didn't particularly enjoy doing. I was really more interested in looking after the really sick patients. But I started to see hormone replacement therapy in its infancy, and I had questions. And I did a PhD in molecular biology looking at bits of ovaries, but I also started doing some studies involving the women in the menopause clinic. And much to my surprise, I had initial findings that were very provocative, particularly regarding the use of testosterone in women. And this really snowballed into me asking more questions and getting more involved. And so you sort of like open the door and you just walk through it. And 40 something years later, here I am.
Is that right? 40 something years. That's incredible.
I started in the 80s. So yeah.
Yeah. Well done. And you know, for the women all around the world, from what all of the things that you've been able to research and the findings that you've had from your research, we are all the better for it.
Well, I try and contribute. I do my best.
So you briefly talked about endocrinology and your specialization in that area. So can you just explain a little more in layman's terms what an endocrinologist does? You mentioned hormones, so yeah, a little bit more about that for us.
So hormone is a chemical that's produced in one part of the body, like your thyroid makes thyroid hormones, that has actions in cells in other parts of the body. So your thyroid hormone will act on muscle and bone and in your brain. So estrogen's made in your ovaries, and although it's really important, of course, for making an egg and reproduction, it also has actions on your skin, on your muscle, on your bone, on your blood vessels. So these are hormones. And so anyone who specializes in the consequences of either too much or too little hormones in people is called an endocrinologist. The classic would be diabetes.
Gotcha.
That's the bread and butter of endocrinologists.
Yes. So in your current work now then, your research in the work and area of women's health is very much respected around the world. But I'm interested to hear from the perspective of a researcher and a health communicator. Are you seeing a change in the way women's health is actually viewed by the decision makers, say, for example, in government and the research bodies where all the money is coming from? Do you think that research is also in women's health finally becoming more recognised, which was, very much long overdue?
Look, I think it's become a recognized area because society's changed. So if you go back a number of years, 20 years, a smaller proportion of women were in the workforce when they went through menopause. And a smaller proportion of women were in paid employment. And so a lot of women's health issues that might influence a woman's work functionality are coming to the fore. So women are having a voice in terms of things like heavy bleeding, pelvic pain, endometriosis, menopause, infertility, because women are staying in the workforce longer before they actually start their families or partner and start their families. And so infertility is becoming an issue. So all these things have come to the fore, I think, because of the change of socioeconomic circumstances, very much so. And those change in socioeconomic circumstances gives women a voice.
So is it women are demanding more because of the various issues that you just spoke about?
I think there are multiple factors. Women are demanding more. Then there are, dare I say, opportunists who are hearing that women are demanding more and seeing that this is a commercial opportunity, and that amplifies the voice. I can build a business here. But if I want to build a business, I have to make sure people know there's a problem. So that amplifies the voice. And there's government there are people in government who are genuinely, very personally responsive to the concerns of women, and other people who realize that if they don't get on the bandwagon, that women aren't going to vote for them. So there's voice and there's amplification of voice, and some of it's for good and some of it's for self-interest.
So for yourselves who are working in the research area now, that must be fairly exciting to know at least the light's being shone on and there's more opportunities coming ahead to do the research that's much needed.
Yeah, it's really mixed. I mean, it's I've worked in this area for, as we've said, for a very long time. And suddenly I'm hearing people sort of coming in as sort of the experts. And I'm like, no, actually, that's not right. Where did you get that from? And why are you suddenly more believed than me when I've actually produced the evidence and I've slaved away in this field when nobody wanted to talk about menopause? And then suddenly you're the voice. It's fascinating, really. Fascinating.
It would be, and exceptionally difficult, I imagine, for yourself. Your ears must almost bleed at times when you're hearing some of the rot that's trotted out. And we'll talk about that later in the conversation as well. So you are currently the head of Women's Health Research Program at Monash University. And when I was preparing for this interview, I could see just how incredibly important this research program is for women who are not only in Australia, but from all around the world. So can you just share a little more about what the research program entails and why this is so important?
So I'm always asking, wherein lies the truth? And wherein lies the truth is in several dimensions. It's what is the true experience of women? So the best example I can give of that is, winding back about 15 years, I started seeing an increasing number of women who have had breast cancer coming to see me with menopausal symptoms. And some of them had terrible symptoms untreated. So was this the tip of the iceberg, or was this a small fraction of women who are really in a bad way? And so what we did was we set up a study and recruited just under 2,000 women within their first year of diagnosis of breast cancer. And we followed them every year for 10 years to find out what their journey was and to find out how real is this problem? What are the issues we should be dealing with? What is their voice? And so, and we had all the outcomes of that. And so a lot of the work we do is what's called epidemiology, studies like that, where we recruit thousands of women and ask them a whole lot of questions. And when we recruit women, we recruit them through the electoral roll. And for people listening who are not in Australia, it's compulsory to vote. So everybody's on the electoral roll. So you can randomly recruit people. So you get a random sample of the community, and to make sure that people in your study actually look like women who live in Australia, not some biased group. And we do a study to look at, well, how common is this symptom, or how common is this problem in the real world? And they're epidemiological studies. And then we do other studies, which are trials where we do what's called randomized control trials, where we'll recruit, say, 100 women or 200 women, and they get treatment A or treatment B. One's a placebo. No one knows who's getting what. And then we see if the treatment we're really interested in is really more effective than dummy placebo therapy. So we do clinical trials and population-based studies to try and find out what the real problems are, and then can we do something about this?
And so for then so long, the lens of women's health has been focused on the first half of a woman's life, the early reproductive stages, pregnancy and so forth. But as we know, our 40s and our 50s, and certainly beyond, are critical for just how well we age and how long we live. So the body of work the research program has produced would be vast, but could you share more about a couple of the important findings that all women really should know about, but perhaps we may not be aware of?
Oh gosh, the findings that we should know about. I wouldn't know where to start with that. We've done studies of many thousands of women now from the age of 18 through to 94. I think, let me think of a couple of key findings. Well, particularly of midlife and menopause, the majority of women do not have a bad menopause. I'm talking about the majority, 70%. 70% of women do not have severe symptoms. About 30% do, but of the women that do, those symptoms start to get better as you get, into menopause. So once menopause is the final cessation of either your periods, or if you've had a hysterectomy, your ovaries functioning. And once your periods have stopped completely, the symptoms over the next few years start to resolve. So about 1 in 3 women have symptoms that are bothersome, but they mostly resolve with time. So that's a really good thing for women to know. And the classic symptom, for example, would be memory, difficulty with memory, walking into a room, not knowing why you came into the room, struggling to remember what you just told me. That improves, actually. It doesn't, if it's bad, it actually gets better.
Okay.
So there are a lot of menopausal symptoms that really do get better in the very first few years, and not every woman needs hormones. I think that's an important finding. Another finding is that, as we know, as women age, there are changes in our bodies, including, say, the vagina, and that is associated with, and bladder, and that's associated with discomfort, but also irritation and increased risk of urinary tract infections, etc. And despite vaginal estrogen therapy being incredibly effective to reduce vaginal dryness, reduce urinary tract infections, reduce bladder irritability, only about 6% of women are prescribed vaginal estrogen. So, so women should be speaking to their doctors about that. So, things are being undertreated. So I wouldn't know where to start to do the finding.
It was how long are the piece of string?
Yeah.
Sorry about that. Sorry about asking you one of those tough questions. But let's think about right when you mentioned you mentioned 6% of women are prescribed vaginal estrogen. So how do we get that information out to the doctors who do the prescribing? Well,
I think I think we are gradually fixing this, I hope. But there really has been a hiatus in knowledge. One of our important study findings is that we did a big qualitative study of women, which means we don't just add up numbers, but we ask women their opinions and thoughts and beliefs. And this study included women from across Australia of different ages. And women have a very good understanding of menopause. They understand it's when the periods stop and you no longer can get pregnant and you might get hot flushes and night sweats. But women had a very poor understanding of the link between menopause and bone loss. And they felt that you only went and talked to a doctor about it if you felt really, really bad. It was almost like you're almost a failure, or you have to be in a really bad, it's really okay to go and speak to your doctor if you're in a bad way. And on the other side of it, we spoke to doctors, pharmacists, and gynecologists, and they all agreed that menopausal hormone therapy or vaginal estrogen was really good, could be really effective. But first off, that's not what they would recommend, because they don't think that's what women want, and because they didn't feel really confident in prescribing these therapies. So we've got issues on both the side of the community of women not understanding that it's okay to go and speak to your doctor and your symptoms are not too trivial. And we've got doctors feeling uncertain about actually how to deliver the care. And we've got to work on both sides.
And in Australia, we've had Senate recommendations going to the government, the Senate recommendations.
Yep.
Perhaps and hopefully one of those recommendations would be to have an increase in education for those primary caregivers as far as the those sort of results that you were just talking about then?
Yeah, we're working on education across the whole spectrum of the community.
And this generation of women, I think too, also, Professor, would be advocating more for themselves. I certainly know, say, my mum's generation, you never question the doctor. You would never go saying you want something. You would wait and that would be received. So perhaps self-advocacy is so important now, I suppose, as a woman.
Oh, I think absolutely. And I think that hopefully that need will gradually diminish with increasing awareness that women have the right to have treatments if they need them.
So we'll talk about menopause and hormone therapy shortly. Before we do, I've just got 2 questions. So firstly, can you explain why is it so important for women in midlife to prioritise their health and their wellness? And secondly, what are just a couple of, off the top of your head, simple lifestyle changes backed by research that you may have done or have come across that we know can not only improve how you feel today, but more importantly, how well you might age into the future?
Well, I think the second point you've made is really critical, that everybody's health today is partly predicted by their health in the past. So, if you were ever a heavy smoker or a heavy drinker or had a terrible diet, that is going to influence your health today, whether you did it when you were 15, 30 or 40 going forward. So every point of life is important for your future health. For women at midlife, it's a time when our bodies do undergo change. It's a time where menopause will increase a woman's tendency to gain central abdominal fat, so get fatter tummies and the spare tire. It will impact cholesterol levels. The gradual increase in weight with age tends to be a environmental factor, not so much just a hormonal factor. So women particularly start to gain weight with age. And so it's an incredibly important time to be looking at your lifestyle, how much physical activity you have. It's a time when everyone's talking about the sandwich generation. We understand it's a collision between work, children, parents, obligations, financial stress. Doing a job, you may or may not like your job, but a lot of women are doing jobs that they don't particularly like, but can't leave work because they need the superannuation still and they need the income. But still making sure that you take time for your mental health, time for yourself. So you're not getting stressed out of your tree. So it's about physical health, nutritional health, mental health, personal downtime, and time to actually have fun. Yeah. Find something you enjoy. Find something gives you happiness and give yourself time for that. Women are very good at not giving themselves time. So I think it is the gateway to the second half of your life. It's not all going to be fixed by being on HRT. HRT is not the elixir of youth, MHT or HRT, whatever people call it. Hormones are not the elixir of youth. You've got to do some outside work. And the outside work is actually creating a healthy environment for yourself, which will then pay off because if you're partnered, it will trickle over. It'll have a ripple effect to your partner, to your family, to your grandchildren, to your friends, to everybody.
That's right. So it's really looking at it as a form of self-care, and that self-care then will the ripple effect is quite.
Absolutely.
Yep. Thank you. So now women are hungry for facts, and I love how you're now using your new Instagram platform to share some of those facts in small, short, bite-sized videos, just to dispel some of the myths, and particularly when it comes to menopause, hormones and hormone therapy. And as I said at the start of the conversation, there is so much information out there, and it can be hard to sort out the truth when all you're trying to do is find an answer to your problem. Influencers with large followers, those who aren't qualified in medicine, let alone the specialised area of women's health and menopause, are sharing misinformation that is clearly wrong and in some cases could be dangerous. And even some of the well-known and popular doctors specialising in women's health can share misinformation on social media. So can you give tips for all the women who are out here listening today on how we can sort the fact from the fiction? What can we do? What can that everyday woman do?
I think this is one of the greatest challenges. And in fact, one of the big medical journals, The Lancet, just had a major article on misinformation. It's a real challenge. I mean, I even encounter it, I want to go and purchase something new, and you look on the internet and you go, oh, what do I believe here?
Yeah.
Who do I trust? So I think you can learn a lot from sources like Instagram, but then you should fact check. So go to bodies websites like the Australasian Menopause Society. Is fantastic. They have fact sheets for the community. The International Menopause Society has fact sheets. Jean Hales for Women's Health has fact sheets. So if you're hearing something, but it's not being supported by a major trusted body, you'd be a little bit suspicious of it. If there's just one idea that you think, oh, that's a bit strange, do I believe it? Go and check it from another source. And I guess I was asked this on a podium years ago with a colleague, and my colleague's answer was also be very aware of people who see everything in black and white. Although I do some myth busting in black and white, but if someone says, oh, there's no blood level of estrogen or dose of estrogen that's not safe, well, think about it and go, if I had estrogen levels in the thousands like a pregnant woman and I'm 55, would that be good for me? Probably not. You know, think about what they're actually saying and don't be guided, but don't be misled by hyperbole and, this is good for everybody and everybody should be take rhubarb tablets, because it's, just have your little antennas up for the sort of I think of the polite word, the sort of,
you can say it,
the nonsense factor,
well, we know what you mean. Yes, we'll have that radar up.
Have your antennas up for that. Do I completely believe this, or is there a little bit of poetic license here?
Because there is some really slick marketing, I suppose, asking yourself the question, if it sounds too good to be true, it possibly is. Is that the way we should be looking at it as well?
Sounds too good to be true, just be a bit suspicious. There's no silver bullet for health. Now, having said that, I've prescribed all the time estrogen for women who have drenching night sweats, they're exhausted, they feel horrible, and they come back and they will say it was life-changing. Well, it is life-changing if you haven't slept for the last 4 months. But that's not life-changing in the same way as perhaps other things that are being promised.
Yes, correct. So not every woman will experience menopause-related symptoms, as you explained earlier. But for those who do, my next question is around that efficacy and safety of the over-the-counter pills, creams, supplements, herbs, teas, anything that's promising an easy solution. And you said, yes, fact check some of those things as well. But do websites such as Jean, and I'm asking on behalf of people who are listening, because you mentioned various things, that with the Menopause Society facts that they have, the fact sheets there, Jean House Women's Health fact sheets have that sort of information as well. What does research say about all of these supplements?
A lot of these, I think the Australasian Menopause Society will has fact sheets on alternative therapies. We actually did a series of very short videos that are on YouTube for the International Menopause Society, and we did a whole series on what happens at menopause, what is HRT, is HRT safe, and there's one on alternative therapies. Nothing has changed, although these were made years ago. That really what we know hasn't changed markedly. Unfortunately, I wish we knew more. But these are also great videos about, what alternative therapies work and what to believe. So the International Menopause Society has information. Most of these organizations do have information that's very, very valid, reliable, trustworthy.
Okay, so I'll make sure that I include links to those various sites that you've recommended for women to go to as well into the show notes. So there can also be other underlying issues apart from declining hormone levels that might give women symptoms that are similar to the menopause symptoms. What sort of tests in particular would you recommend women take at this?
Look, yeah, the two big ones, as women approach menopause, often bleeding becomes heavier, and iron deficiency is common. And if you're iron deficient, you're going to be tired, you're going to be dragging yourself around, and that's not menopause, that's iron deficiency. A lot of women also, if you happen to be a person who's chosen to become vegetarian, or you're much more at risk of iron deficiency, but I'm seeing increasingly numbers of women who are vegan. And unless you're taking things, zinc supplements, I'm seeing zinc deficiency, which will cause bone loss, fatigue, hair loss. Iron deficiency is a cause of hair loss as well. So nutritional care is really important. And then the other thing is thyroid disease often declares itself in women in their 40s and 50s for the first time. So an overactive thyroid will make you anxious, agitated, hot and sweaty, whereas an underactive thyroid will make you fatigued, sleepy, flat, depressed. So thyroid function, iron levels are very important. And while joint aches and pains can be a classic symptom of menopause, joint aches and pains, new joint aches and pains can also be the sort of hallmark of the development of an inflammatory arthritis. So there are a lot of things that if women are getting really dramatic symptoms, we need to exclude, like inflammatory arthritis, thyroid disease, iron deficiency, etc. So this is the time to have a good general health check.
Yeah. So again,
and blood pressure.
Yeah, exactly. Yes. So how often should women be having, say, their blood pressure test? Every time they go to the doctor?
Well, I guess it depends. If you go to the doctor every 6 weeks, they're probably not. But women should certainly, if you've always had low blood pressure, you would still have a check going through menopause. And if it remains low every time you see your doctor, then you don't need to run back every 6 months or 12 months just for a blood pressure check. It's likely to remain low, but if it starts edging up, then you need to keep an eye on it. And you can get your blood pressure checked often at the local pharmacy, or if you've got a family history of hypertension or you think your blood pressure is unstable, you can get a blood pressure monitor and just check it at home.
That's true too. So for women who might have an existing condition, say, for example, thyroid disorder, or say Hashimoto's thyroiditis is a very common one for women to have. Do things like that change during menopause? What would do symptoms increase? Do they decrease? What happens there?
No, there's no real change with any of these conditions specifically with menopause, but there are some of the various forms of hormone therapy that might be prescribed that could alter the effectiveness of thyroid supplements, for example. And so any woman taking thyroxine, the thyroid replacement, if they go onto hormone therapy or off hormone therapy, they may need to have their blood level of their thyroid hormone therapy checked.
Right.
Because that can wax and wane a bit or be interfered with by some hormonal therapies. But the actual condition, it's more that this is an age at which conditions start to become manifest, and you can get substantial overlap.
Okay, so it's a basic rule. What we measure, we can then monitor over time as well. Yeah. Now, many women are told or feel like they want to have a test to see whether or not they're in perimenopause. Some choose or are told to have a blood test, or some an expensive Dutch test to determine whether or not they are in perimenopause. What advice do you give to women about that?
Okay, so let's take a woman under 45 whose periods have become irregular. We would strongly recommend that somebody under 45 would definitely go and have a series of blood tests, because there are reasons other than menopause that a woman under 45 might start getting irregular periods. And the average age of menopause is after 45. So if a 42-year-old suddenly hasn't had a period for 6 months, obviously you rule out pregnancy, but then we'd rule out a lot of other things that could be causing the loss of periods. So that person should have a blood test, not just for menopause, but to look for other reasons. For a woman over 45 who's menstruating, if their periods start to become a bit irregular, they start getting some symptoms, you don't need a blood test. A blood test is a waste of time. One, you don't need it because the fact that your periods have become irregular and you're starting to get some flushes or sweats, that's the diagnosis. The second thing is the blood tests are just all over the shop. Your estrogen could be up one day, down the next, up. That's why the menopause symptoms go all over the shop. So there is no point doing a blood test, because 1 minute it might look like a 25-year-old and the next minute like your blood profile might look like a 65-year-old. It's unhelpful. There are situations where we would suggest it's possible to do, or appropriate to do it. So 49-year-old woman had a hysterectomy, got classic hot flashes and night sweats. I am not going to order a blood test. For all purposes, they're menopausal or perimenopausal. But if you've got a 49-year-old woman, no hot flashes and no night sweats, but is feeling a bit teary, a bit down, this could be menopause or could be depressive symptoms. And in that situation, it can be helpful, because if the hormone profile screams menopausal changes, you would treat with hormones. If the hormone profile is absolutely not a shadow of doubt, not looking menopausal, you've got to say, well, we need to understand what's going on here about your mood and stuff. So when someone's not got the classic bleeding pattern to address, a blood test can be helpful. You don't need to do these expensive Dutch urine tests. I mean, honestly, there is nothing they will offer that a blood test won't offer. And most of the time, we do not need a blood test.
Great. Good. And so if it's, say, for example, we'll talk about hormone therapy now. So could you just briefly, and I know it's hard because it's such a huge topic, who does hormone therapy help? What does it actually do? And the big thing that everybody wants to double check, is it safe?
Okay. There's clarity at the moment that all the studies we have to date show that estrogen will help classic menopausal symptoms, hot flashes and night sweats, sleep deprivation, new onset anxiety, low mood, not depression. I'm not talking about severe medical depression, but low mood, black mood, feeling really negative, loss of confidence, vaginal dryness, and if there's new onset, low desire, it can help low sexual function. Not a lot, but it can help a lot. It can help some women, not everybody. So the reason for going on hormone therapy is symptoms. Reason 1, 2, and 3 are symptoms, symptoms, symptoms. If a woman comes to see me and she's going through or has gone through menopause, her period stopped 18 months ago, 12 months ago, no symptoms that bother her, I would then do a bone density. And if the bone density is on the low side, if she has clear osteoporosis, I will go and investigate, is there an underlying reason to be treated? If it's on the low side but not osteoporosis, I would consider hormone replacement therapy for the prevention of further bone loss and fracture. And with the woman with osteoporosis, I would, once investigated for other possible causes, again, I would consider prescribing hormone therapy, estrogen, specifically to protect her bones, prevent loss, and maybe build some more bone. So the 2 reasons now, and in Australia and other countries, menopausal hormone therapy is approved for treatment of symptoms and prevention of bone loss and fracture. It is not prescribed to prevent cognitive decline or dementia. The evidence is not there, even though plenty of people want to say that. Although menopause is associated with change in a lot of cardiac factors like cholesterol, like central abdominal fat, maybe even our sensitivity to insulin. And if you give estrogen, you can improve these things. The evidence, though, that over the long term you will substantially reduce heart disease is not there. So if you want to prevent heart disease, it's exercise, blood pressure, low cholesterol, all the things we do, good diet, we already know about. If estrogen is going to make any difference, it's so little, and we can't pick the individual that's going to make the big difference for. who goes through natural menopause. So hormone therapy should not be prescribed to prevent dementia or heart disease as single reasons.
Mm-hmm.
There's a caveat on that. For women under the age of 45 who go through early menopause, it appears that using estrogen may prevent early heart disease. And we would recommend that unless a woman's gone through early menopause for something like breast cancer, we would recommend that all women who go through early menopause should be on HRT, at least until the average age of menopause. But they're a different group.
Mm-hmm. Mm-hmm.
Women over 45, hormone therapy should not be commenced only to prevent disease.
Right. And there's a variety of hormone therapies that women can go on, gels, patches, tablets. So is it trying to find what is working for you and the dosing? So does that take time for some women, or do some women are some women finding that they just can't take any therapies they want to try, they're being prescribed and it's just not working for them? Is that a case also for some women?
Well, it's a little bit like the contraceptive pill, you know. If some women go on they go on a common garden contraceptive pill and they're just happy as anything.
Mm-hmm.
Other women try multiple different pills, IUDs, all sorts of things, and they just can't find something that works for them. Mm-hmm. So I think women need to be aware that there are lots of options. It's not one size fits all. There's a huge push for women to be using patches and gels. And then if they're not working, just keep upping the dose. There's no evidence that that's the best approach. And I do have patients still taking estrogen tablets because for some women, that is best.
Mm-hmm.
There are so every woman who goes on hormone therapy will be given estrogen. And if they have had a hysterectomy, they will only take estrogen. If they have not had a hysterectomy, they'll take estrogen and a progestogen, which protects the lining of the uterus from getting thick.
Mm-hmm.
There are lots of different progestogens. It's not one size fits all. Body identical progesterone is being heavily pushed at the moment, but for some women that is not potent enough to stop their lining from thickening up or having unwanted bleeding. And it's not a failure to use one of the other progestogens. They're not as unsafe as people keep making out.
Okay. And that's, yeah, again, to find a doctor who is aware of all of this can sometimes be problematic for women as well.
Yeah, but I think the problem is that there's been such a push that you must use a patch or a gel, you must use body identical progesterone, that no one knows how to prescribe anything else within the range of safety. And everybody's just saying, oh, everything else is dangerous and terrible. It's actually not. And there are lots of ways you can use alternatives to patches and gels and progesterone very safely, very effectively.
So let's talk about the compound, what is bioidentical, like you talked about the bioidentical, body identical hormones. And then women have also got, let's have a prescription. A doctor will write you a script for this and then you take it to the pharmacy and they will compound up your, something that is meant just for you. Can you talk through a little bit about that side of therapies and how that's used in some cases and why that may not be a good idea?
So back in the sort of 1980s, we only had estrogen tablets.
Mm-hmm.
And the way you absorb the estrogen tablets is the estrogen used to have to be mixed, sort of bound to other complexes to be absorbed.
Mm-hmm.
But when we then moved on to being used in patches and gels, they contain estradiol, which is exactly what our bodies make. Our ovaries make estradiol. And that is body identical, bioidentical, whatever you want. There's no estrogen tree, but it's made in the factory. And for it to be in a patch or a gel and approved by a drug regulatory agency like the FDA, for example, then the company that makes it has to show what doses, give what blood levels, give what effectiveness. But when those patches and gels were only in their infancy of being available, what emerged was also doctors writing prescriptions, so many milligrams of this and that, and you take it off to a pharmacy and they mix it up and give it to you in little form, either as a cream or as something you suck in your mouth.
Mm-hmm.
They're not more body identical than what the regulators have approved, but there's no studies showing what dose should be in the cream or the thing you suck, the lozenge, to be effective.
Mm-hmm. Mm-hmm.
What dose will most women, need to reduce how much will get through the skin? So I've seen women using estrogen creams with massive doses of estrogen in their blood in the thousands, and some spending money on estrogen cream and you can't detect it in the blood. None of it's absorbed. So it's a bit of a best guess sort of thing.
Okay.
And then people are mixing up progesterone, DHEA, testosterone, all sorts of things, and it's all a bit of a best guess. So all of the body identical stuff that can be mixed up in a chemist is available in a form that has been regulator approved, and women should be using the regulator approved stuff.
Gotcha. Okay, and for women then who are symptomatic, when is the best time to start therapy, and how long should women stay on therapy after she's reached menopause?
You start therapy when the symptoms get bad, when the symptoms are, it's like saying, when do you take something for a headache? Yeah. When it's interfering with your life and what you're trying to do.
Mm-hmm.
How long is as long as you need it? And all the guidelines say the same thing. So, and how do you know how long you need it? Women are clever people. Women will tell me. I decided I'd just reduce it, and I decided I'd sort of use less gel or cut my patch in half, and within 2 days, oh my gosh, it was terrible. They still need it. Within 6 weeks, I hadn't noticed any difference, so I'm still using this lower dose. Fine. Or if I ask a patient, what happens if you go away for a week and you forget to take it with you? Either I never forget to take it with me because it's too horrible if I do, or I don't notice anything. Let's try reducing the dose a bit.
Yeah, yeah.
It's really interesting, but it just comes about.
There's almost like I've heard in certain circles that you must only have be on hormone therapy for a certain amount of time, and then it's too dangerous for your body. And so women are then just saying, what do I do? Because on one hand, you might hear one person saying that, or one specialist saying that, and another specialist will give you other advice. So it can be tricky, but we've heard it from the from the person who is doing the research.
But none of even the guidelines for the last 5 years have not said you must stop. It's as long as there's a reason to treat, and the reason to treat would be recurrence of symptoms or bone protection.
And what is then the latest on the breast cancer risk data coming through regarding body identical estrogen progesterone use for more than 5 years? Is that something that's...
This is something that worries me a bit, in that there's a lot of people saying, and I read it in a medical article recently, that progesterone does not increase the risk of breast cancer. I would never say that to a patient because we don't know. If you look at the Women's Health Initiative study that used conjugated complex estrogens in tablets with a synthetic progestin in a pill, after around 5 years, there was an increased risk of breast cancer. Now, this didn't really clearly emerge until 5 years.
Mm-hmm.
The risk is small. It's like a 1.2-fold in risk. It's not doubling of risk, but it's small and it's statistically real. If you look at body identical progesterone, once we don't have any clinical trials, randomized placebo-controlled trials beyond about 12 months of use. And if you look at the population data, once you get to about 5 years of use, there seems to be a weak signal that there may be an increased risk of breast cancer. The numbers are small, but we don't know. And we need that data desperately. But telling a woman that if you take estradiol as a patch or gel and body identical progesterone, that will not increase your risk of breast cancer. That is I think that's misleading because we don't know. And I think women have the right to know that we don't know.
Mm.
The studies that suggest it's probably safe are extremely small. And as I said, the largest randomized controlled trial is, up to, for estrogen plus progesterone every day is 12 months with it for 12 days, 200 milligrams for 12 days a month. It's only 3 years. So we don't know.
Gotcha. Okay. So it's a watch this space.
Yeah, there are potential risks that the risks may be extremely small, but we don't know.
Gotcha. Okay. And for women then who have had a hysterectomy due to, say, endometriosis, should they be prescribed progesterone? And if they are, how long should they be on progesterone?
It's a very important question. And when I see a patient who's had hysterectomy for endometriosis, if they had it 20 years ago, they haven't had any symptoms, I'm not really worried. If they've had it in the last, say, 2 or 3 years, I will always speak with their gynecologist and ask their opinion.
Mm-hmm.
And often these are women who will go on progesterone or progestin, even if it's a tiny dose for a few days a month, just to give them a little bit of comfort to not have a recurrence of the endometriosis, because endometriosis is fed by estrogen.
Yes, gotcha. Okay.
So this is an important point for your listening audience is if you've got a complicated history and you're being looked after by a gynecologist for endometriosis, or you've had a thrombosis in the past and you see a hematologist, you want to make sure that the doctor prescribing your hormones is communicating with the other members of your healthcare team.
Mm-hmm.
So you don't get doctor prescribes estrogen, other doctor says, oh my God, you shouldn't be on that. And then you're the meat and the sandwich.
Mm-hmm.
But also you'll get the best health outcome if your doctors talk to each other.
Yes. That's the importance of having a health team, isn't it? To see everybody as a team helping you and your particular cases. Now, if we can just briefly go on then on about testosterone, because that is a topic that's being discussed more and more, and especially on social media, it's everywhere. And because of that, there are plenty of myths that are circulating. So how do we test for low testosterone? Is that such a thing? And who would benefit from testosterone? How effective is it?
One, we do not test for low testosterone. End of story. And the reason we don't is twofold.
Mm-hmm.
Number one, commercial labs where you will go and get your blood tested does not have the sophistication in routine testing to measure low from very low. So they're using the same test that's measuring blood levels in men that are 10 and 20 and 30 to try and see the difference between 0.4 and 0.6. The test cannot discriminate between 0.4 and 0.6 and 1.1. It's just too blunt an instrument.
Mm-hmm.
That's the first thing. The second thing, and there's no cutoff level as to what low actually is.
Mm-hmm.
The second thing is that once you go through menopause, your adrenal glands make hormones. These go into your cells, like in your skin or in your bone or muscle. And in those cells, those hormones are turned into testosterone. They do whatever they need to do in those cells. The testosterone's broken down, and the breakdown products go into the blood. And any testosterone in your blood's really spillover of a little bit extra that's been made in the cells, but doesn't tell you what's happening in the cell.
Mm-hmm.
It's like a married couple looks happy, but they're fighting in their bedroom, You don't know what's happening in the house.
Okay.
The blood level doesn't tell you what's happening in the house. You don't know if there's lots of testosterone in the house or not very much. And so the blood level, one, it's unreliable at low levels. And two, it doesn't tell you what's happening in the cells. So why test it anyway?
Mm-hmm.
And all the studies we've done involving hundreds of women, the criteria to go into the study was not your blood testosterone level. What we've been able to show is that for the majority of women who are postmenopausal with low sexual desire that is of recent onset that's bothering them, testosterone is likely to help improve their desire. It's not dramatic. You're not suddenly really horny, but you start having sexual thoughts or being in just more responsive to overtures being made to you by your sexual partner. So increased sexual responsiveness. Every woman treated with testosterone will not experience this, and that's because not every woman, sexual problems are their hormones, it's other issues. But studies so far have not identified any other very clear benefits of testosterone. So if you look at, say, cognitive function, some studies suggest maybe a subtle benefit of word finding, and other studies show no benefit. So it's a complete area of uncertainty. So no one should be taking testosterone with the belief that it's going to fix something else.
That's important to know, particularly with all of the noise around at the moment. Now, if you could wave a magic wand, what would you love to see happen in the area of midlife women's health?
I mean, there's no question that there is a vast need by many women to use hormone therapy to manage their menopausal symptoms. I would love to see a really high quality randomized placebo-controlled trial of estrogen as a tablet, patch, gel, different formulations with progesterone versus another synthetic progestin to see, or versus placebo to see risks versus benefits. We will never do this study. And the reason we will never do it, no one's going to go in the placebo arm. That study was able to be done in the 1990s. The Women's Health Initiative studies altogether enrolled 27,000 women. Half got estrogen or estrogen plus progestin, half got placebo. They ran them, the longest one was up to 7 years. We're never going to do that in anywhere in the world, because if women now will say, but I'm not going to spend years on placebo getting hot flashes and night sweats if I know estrogen's going to help me. So the safety of this, I don't think, or the benefits in terms of other outcomes is not going to be established for the current products we're using today. I would love to see that study, but it won't occur. And it won't occur also because it costs multiple millions of dollars. So I would like to see a study of testosterone and cognitive function. We did one where we used a battery of computerized testing in 96 women, half got testosterone, half got placebo. Most aspects of cognition showed no improvement. Remembering words from a shopping list improved very, very marginally, 1.5 extra words. We don't know if this was a chance finding or if it's real. I'd love to be able to repeat that in a much larger group. But so I think a few more studies with testosterone, but the big estrogen studies we need, I can't see happening.
Well, that's a shame. It's a shame for you as a researcher that you don't have that actual data. So there has been incredible information that you've shared with us today. And to finish our time, I've just got a couple of very short, simple, rapid-fire questions just to wrap up. What's the number one takeaway message you'd love to leave our listeners with?
Of the most controversial stuff at the moment, menopausal hormone therapy can be extremely effective for women with symptoms, but not for women without symptoms, or healthy, extremely good for protection of bone loss. But you don't need to take megadoses. You don't need to be using 2 or 3 times the upper limit of standard therapy. If patches and gels aren't working, don't just keep slapping more and more and more on. Look at the alternative ways of having estrogen. But be cautious about anyone who keeps prescribing more higher and higher and higher doses of hormone therapy. And if you're unsure of what's going on, either get a second opinion or go and look at the reliable websites.
Okay. And can I just ask you a very quick question on that? I said it was going to be rapid fire, but you know how you were just talking about putting more and more on? One of the arguments is saying that your body's not absorbing it properly. Is that a thing?
One of the proponents of using high dose estrogen just referred to a paper that's been published in Menopause showing women using very high dose estrogen, and about a third of those, eyeballing it, looks like something like 25% to a third of the women in that study, supposedly not absorbing it, had blood levels that look like pregnant women.
Oh.
So blood estrogen levels over 1,000. The average premenopausal woman would have a blood level of 400 picomoles per litre across the cycle. And this study where women are getting mega doses of patches and gels, some are using patches and gels together, they've got blood levels of 1, 2, 3, 4, up to 10,000 picomoles per litre, which is a pregnancy level. So this is not absorbing. This is possibly treating women with mega doses of estrogen. They are absorbing it, but it's not fixing symptoms because the symptoms that are being treated are probably not due to menopause.
Gotcha. Okay. Thank you. Thank you for clarifying that. So on a personal note then, what are a couple of your daily non-negotiables for your own health and wellness?
Exercise.
Your favourite sort? What do you like doing?
I swim several times a week in a squad. So I swam 2.5K this morning.
Holy, well done.
I do that 2 or 3 times a week. So, and I do other exercise. I'm a passionate skier. Snow skiing.
Yes.
And family.
Beautiful. Beautiful. That connection time. And what are you most looking forward to in this next half of life?
My next half of life. Oh, I just enjoying life, doing the things that make me happy. Still working for a bit more, but training junior doctors, training people who work with me in research, spending time with family, and just finding health and happiness.
And if you could look into the future, what do you hope 80-year-old Susan will say about current day Susan?
Oh, gosh. No regrets, I hope.
No, I hope too. So thank you so much for your time today. We really appreciate you sharing your amazing knowledge with us, and all the very best for the future. And let's hope, cross fingers, that someone will wave a magic wand and you'll get that research sorted out.
Thanks so much, Jo. I really enjoyed talking with you.
Likewise. Thanks so much for spending your time with me today. I hope you feel inspired to make the next chapter of your life the best one yet. And remember to share this episode with someone else who would love it, and connect with me on Instagram or LinkedIn at Jo Clark Coaching. All the links and the details from today's episode are in the show notes or at joclarkcoaching.com. And if you enjoyed this episode, please follow or subscribe this show on your favourite podcast app and leave a 5-star rating and review. This helps more midlife women find these empowering conversations. I can't wait to chat with you next week. Until then, take care and keep creating a life that you love.